Yeah, excellent surgery, Paul. I'm Dr. Manoj Vadva here.
Yes.
May we request by the time 70 is setting down, you can finish your talk right from the OR on gap balancing in TKR.
Okay.
Yeah, because you have a flight to catch up, so we can club it along with this.
Okay. Okay. I've never given a lecture while operating, but this is great. Measured resection versus gap balancing. There's two ways of going into it. You can do like my dog on the right, the silver lab. You can kind of wade into it, or you can do like my yellow lab, just jump into it. For the junior registers, the junior people, the beauty of this is you have to make a distal femoral cut, and you have to make a proximal tibial cut. So as far as making a proximal tibial cut, you have to do it whether you're gap balance or measured resection. How do I click to change these? Okay, so joint stability, gap balancing, steps, and my clinical experience. Next. Joint stability is dependent on congruency, alignment, symmetric flexion and extension areas is the most important thing. You want to get a well-fixed, well-aligned, stable knee. Next. The MCL and LCL, we had a great lecture on day one about repairing the MCL, and this has a lot to do with it. 30 to 60 degrees of flexion is its big role. The origin is near the functional flexion axis on the femur, and you want to have symmetry throughout the range of motion. Next. Continuous interplay between the collaterals, the flexion extension spaces, the mechanical axis. If you do all three of them, you have a balanced knee. Next. So techniques, you have measured resection and you have gap balancing. Has anyone in the crowd done gap balancing? I'm going to let you, Dr. Manoush, tell me that there's people raising their hand. So the measured resection, what you're going to do is basically it's the most reproducible one, I think, early on. You're just going to put back what you took off. You have a measured resection based on bone. All your references are on bone, not soft tissue. Next. Measured resection. Next. So you make your distal femoral cut. Next. And then you make your 4-in-1 block cut. So now you've already committed to your distal femoral cut and your posterior and anterior femoral cut. You make your tibial cut, and then you balance out your flexion and extension gap. Problem is that everybody assumes, and looking at the videos here in India, I don't think there was one knee shown with 3 degrees of Varus. So, you know, this may be a good way to try to do a different approach. But it does give you a reproducible platform. Every orthopedic resident, every orthopedic surgeon somewhere learns measured resection. Next. 3 degrees is what I'm saying is not always there. So this can kind of go out of the window when you're trying to balance because you have a flexion gap asymmetry trying to correct the rotation. So gap balancing, it's measured resection of the distal femur and the proximal tibia. So make your distal femoral cut, make your proximal tibial cut. At that point, you haven't committed to either system, whether you're going to do a measured resection or a gap balancing. So what you want to do is you want to, go ahead to the next slide. You want to have a perfect rectangle. You want to have flexion and extension gaps equal, but you want your rotation set around your tibia so that no matter where you are in the curve, especially with a single radius implant, which everybody seems to have, you'll have isometry all the way through. So you do this, you start out, you do your distal femoral, proximal tibia, remove the osteophytes, and then you do your balancing in extension. You try to get it even, so the extension gap is determined right now. All the ligament releases are done in the extension stage. You flex the knee up, and a swiveling balancer that Joe Jenkowitz and Mark McBride, I don't know who really designed it, but they fight back and forth that they both did. So you tension this, but you knew your size of your gap, whether it was 20 millimeters, which is a 10 and a 10, or 19. Every implant's a little different, but on the DJO, it's a 19, 21, 23. So you know that number you have to recreate. As you tension, this is where I think the the art of this comes into play, and it may not be for the junior-most guys. You have to feel the collaterals. Can you tell the collaterals are tensioned the same as they were when you're in extension? If you can tell that, then this is a good system. You can shift it up and back. So what we were talking about yesterday is shifting this too much takes you out of that paradigm of the 9 boxes, too tight in flexion, too tight in extension. When you start shifting things, you change. I've got this on and I rarely shift more than 1 millimeter either way. Next. So there's your cutting guide. It makes your sizing guide. You finish your femoral cuts and your trial. That does your drill hole. Here's a 58-year-old, this is a typical Oklahoma female, BMI of 41. This is her post-operatively. And next. I don't know why it does this. So she's 3 weeks out. And this is what we call the Oklahoma fat crease, is when you flex back in your shin, or your, go back. Just, let's see that video. Just want to see the end of the video. So she's got full extension, but this is the Oklahoma fat crease. Your calf hits your thigh, and they're thrilled with that motion because they can't go anymore. Quick summary, those are my horses. Next slide. Principles, tibial cuts are neutral, a coronal plane. The extension gap is the only one that requires active balancing. So the only time you have to do soft tissue release is on extension. Flexion will follow that, and all your cuts and all your rotation will be guided by soft tissue. Next. This is my experience. Like I said the other day, a third of my practice is revisions. So do I have the numbers to say that I think gap balancing is the new coming? I don't. I mean, I have 200, since the last lecture, I think I've done another 50. We have 215, and I just use the Empower and the 3D. Can I say that they're going to be better long term? I can't right now. I mean, this is a short term. Next. So the important thing about this slide is for the junior registers, if you make your distal femoral cut, you make your proximal tibial cut, and you try to do gap balance, hold on a sec, don't go too far. If you try to do the gap balancing and it doesn't feel right, things look wrong, stop and go back to your measured resection. You haven't burnt any bridges. You've made your 2 cuts. We were at a meeting several years ago and they said, are you a gap balancer surgeon? Yes. Are you a gap balancer surgeon? No. Are you a gap balancer surgeon? Maybe. We all get around to balancing out the knee one way or another. I didn't really know the difference, and still I don't understand the difference. The only main take home is you can always bail out if you don't feel comfortable at that point. Thank you.